Guys, when you're taking care of people with dementia, you've got to be flexible. You've got to be patient and you've got to be calm. You also have to think, could pain be driving this? Because when people are in pain, these are the experiences they have. A lot of people respond to the behavior when in reality, they should be responding to the emotion. If you ever look at really gifted social workers, they don't respond to the behavior. The behavior everybody has, right? Like I can have a behavior, I can be frustrated about a certain situation. But what really talented people will do is they'll focus on the emotion behind it. And I don't argue. I don't try to convince somebody. Okay. There's no sense in doing that. All right. There's two things you never argue about, right? Religion and politics. Because you walk out of the room feeling the exact same way you felt before, only now you're pissed off. Okay. So don't argue or try to convince. Okay. Simply respond to the emotion behind it. And use memory aids. There's a reason why you see on walkers, don't forget your walker, don't forget your key, use memory aids for people, okay? Acknowledge requests and respond to them and look for reasons or triggers behind every single behavior that you see. And the other thing is this, guys, and I've got to put a plug in for my own profession. You know why I'm a geriatrician? It's a subspecialty of internal medicine. So when people ask me what I do and I say I'm a geriatrician, they're like, well, what's that? I'm like, well, you know what internal medicine is, right? Like when you go to a hospital, you see a hospitalist sitting there. That's a specialty. It's a subspecialty of internal med, being a hospitalist. Well, being a geriatrician is a subspecialty of internal med, and it's very unique. It comes to the table with its own unique subset of thoughts behind care. It's a philosophical care as well. For anybody who has done geriatrics, you know that. There's a lot of philosophy behind our care, okay? There's less academics because it's a newer profession, okay? But if you're really having a go with somebody, guys, consult a geriatrician. They will start to use meds that have more than one benefit. Rather than taking 4 pills, you'll take 1, all right? They'll look at drugs that aren't needed. Guys, there's not a lot of value in a statin. There's not a lot of value even in your antihypertensives when you're majorly demented and you're falling. All right. There's not a lot of value in drugs like osteoporotic meds when you're older. Okay. You really have a thought. We really have a thought process about where value is and where value isn't. And if you are a caregiver, you have to do me this favor. Don't ever take the behavior personally. You guys, this is not a reflection of the person, right? It's a reflection of the pathology. And so when you get frustrated by some of the behaviors, I say, remember, this is not the person, this is the disease. The pathology drives it, all right? And this is another thing that everybody has to remember. There's a reason that CMS has designated dementia as a psychiatric illness, because it is one. It affects all the psychiatry of a person. So you have to share experiences with people. All right. The whole concept of dementia-related care is a novel one. We may think it's old, but it's only about two or 3 decades old. That's it. So by sharing experiences, we get to learn. And by sharing experiences, we tailor the treatments to the person. We get rid of things that don't work. Okay. I can put somebody on an antidepressant. If it doesn't work, then I say, okay. And if I decide to move down a road of a mood stabilizer, but the antidepressant wasn't working, then I wean the antidepressant. Okay. I don't keep people on their drugs longer than they need to be on. That's a telltale sign of a geriatrician, right? Is it needed? No, take it away. Reevaluate it in a year. Let's look at it at the very least in 1 year. Let's relook at those medications.